it needs spending time on it. The peritoneum is a complex structure. Don't peek on it. لا تتلصص على البريتونيوم. نعم. والله بستغرب يا زلمة أنت قاعد بالسر الرابع ما بتسمع. We have to follow Einstein's advice. We have to be smart and spend longer time with the peritoneum. Not a lot of people know the peritoneum well. Okay? Now, the story of the greater omentum. Do you know which organ is this? It is shouting at me, and it is telling me that, look, I am dilated part of the gastrointestinal tract, and I am covered by the liver. Therefore, I must be the stomach. Now, the stomach is covered by peritoneum anteriorly and another layer posteriorly. On this side, it formed the lesser omentum. Why is this the lesser omentum? According to the definition, that lesser omentum is 2 layers of peritoneum between stomach and liver. Right? Now, this layer of peritoneum covering the stomach plus this layer of peritoneum covering the posterior surface of the stomach, they meet. Okay? They meet at this point and form 2 layers. What is next? The 2 layers will come down for some distance. Many times it comes a long distance. And look what is going to happen here. It turns back. The 2 layers, they turn back on itself. Folds upon itself, forming 4 layers. It came down 2 layers, turned and goes up, therefore we end up with 4 layers. 4 layers. And then it reaches this structure. What is this structure? Can't you see? It is talking to you. And it is telling you what this structure is. If this is the stomach, the structure inferior to the stomach is the transverse colon, right? It's a large intestine, and you can see that this is a small intestine and this is large intestine. So this is the transverse colon. These 4 layers, okay, the posterior 2 will cover the transverse colon and meet superiorly and make a transverse mesocolon, and it has its root on posterior abdominal wall. So this is the story of greater omentum. Starts at lower border of the stomach, two layers, they come down, variable distance, turn up, and they make 4 layers, reach the transverse colon. 2 layers will cover, the posterior 2 layers cover the transverse colon, finish with the transverse colon, and they go to the posterior abdominal wall, making the transverse mesocolon. This is the greater omentum. This is the story of greater omentum. If you come to the pelvis, this is the cecum. There are parasical little pouches. Sometimes the intestine gets into these pouches and they get blocked. So we talked about lesser sac and the greater sac, and now we are talking about the little pouches here and there. So there are parasical pouches. If you look at the duodenum, especially at duodenal flexure, and we have paraduodenal spaces, pouches. We have little pouches around the sigmoid colon mesentery. Then we have peritoneal spaces around the liver. There are subphrenic and subhepatic. Sub means inferior to the diaphragm and inferior to the liver. Subhepatic, subphrenic, there are spaces on the left and on the right. The ones on the left, there's left anterior and left posterior. The ones on the right, one space, right subphrenic space. The subhepatic, left subhepatic space and right subhepatic space. This one, the right subhepatic space, is inferior to the right lobe of the liver, and space is something we don't like because it has a problem of difficult to get to. It is called Morrison's pouch. I am going to show you Morrison's pouch. This is what? This is the liver. This is the right lobe, this is the left lobe, and what covers the liver is the diaphragm. So if I put my hand here, it goes between the liver and the diaphragm. This is the right subphrenic space. This is the falciform ligament. I put my hand here, it is going to be in the right anterior subphrenic space. I turn around to the back, this is the right posterior subphrenic space. This is an area of the brain, of the liver, which is not covered by peritoneum. It is called the bare area. Now, the falciform ligament is 2 layers of peritoneum. extends from the anterior abdominal wall to the liver. Look what is going to happen here. It splits. The right fold will go around and then turns back. This is called triangular ligament because it is triangular in shape. Now, the left fold of the falciform ligament will go to the left and also turns back and forms the left triangular ligament and continues posteriorly. So we have a space here, but this is a short one, and there is one subphrenic space, while here there is anterior one and there is posterior one. This is the bare area of the liver, and these arrows are surrounding the bare area, and it's called the coronary ligament of the liver. This is the bare area. This is the falciform ligament. Now we have seen this. This star is between the diaphragm and the liver. This is the left subdiaphragmatic space. And the star here is in the anterior right subdiaphragmatic space. This is a diagram showing you posterior abdominal wall, anterior abdominal wall. This is the peritoneal cavity, and there's an extension of the peritoneal cavity between the liver and diaphragm. We don't like fluids to collect here because it's hard to get when it gets hot, when it coagulates. This is a CT scan of a patient with fluid in the peritoneal cavity. This is the liver, and you see this line here? This is the falciform ligament. And again, this is the falciform ligament. We can see it only in patients who have collection of fluid in the abdomen with CT scan. Here is again the falciform ligament between right and left lobes of the liver. In bold sentence, Morrison's pouch. It is hepatorenal pouch. That's the liver here, and this is the kidney, and this is Morrison's pouch. This is Morrison's pouch, and it is between the right kidney and the liver. This is the right kidney, this is the liver. If fluid comes here, then it is hard for the doctor to take out. If there is a fluid in the peritoneal cavity, you have to open the abdomen to explore why there is a fluid. And you have to take a sucker and you take the fluid out. If you take the fluid out, the fluid stays in these spaces. So you have to know and clean these spaces, especially Morrison's pouch, because it is hard to get to. This is the liver, this is the right kidney, and the fluid will come and occupy this Morrison's pouch. Be sure that there is a question in the exam about Morrison's pouch. Now, if we come down to the pelvis, this is the pelvis of a female, where the peritoneum comes, covers the rectum, turns on the uterus, and covers the anterior part of the uterus. Then it turns on the bladder and covers the dome of the bladder, and then goes up to the anterior abdominal wall. So we have this space, it's called recto-uterine pouch, or pouch of Douglas. And this space here is the vesico-uterine pouch. This is the most dependent part of the abdominal cavity, peritoneal cavity. So it's easy to go through the rectum, open this, and the whole fluid will come out. It's the same information. It's the same information. This is an MRI of, this is the bladder, uterus, and rectum. Space between uterus and bladder, and uterus and rectum, this is pouch of Douglas. Now, in case of the female, the pelvic cavity is divided into two halves by the broad ligament attaching the uterine tube. Pelvic cavity is not divided. Here is a CT scan showing you that this is the uterus and this is the broad ligament. Okay? So we have anterior part and posterior part. The moral of the story. We talked about fluid in the peritoneal cavity, pathologically collecting. We talked about lesser cell, greater cell, pouches, gutters, and we went to the pelvis. Now, if this patient who has a collection of fluid in the abdomen, we have to put him in bed in a semi-recumbent position. It's called Fowler's position. So that any collection of fluid goes to the pelvis. So we can easily take it out. If we let him lie down, fluid will collect into subphrenic, subhepatic Morrison's pouch. The fluid, which contains usually protein, will coagulate, becomes jelly-like. And when you want to take it out, it is going to be hard procedure. That's why patients with problems in the peritoneal cavity, you put the bed like this. Put the bed like this, so that it's called Fowler's position. Don't make the mistake of lying down, or even Trendelenburg, where the head is lower than the feet. Now we have talked about this in men, in women, pouch of Douglas, okay. Talked about the nerve supply of parietal peritoneum and visceral peritoneum. You will find this in the mind map. Okay. Don't forget, ask. Peritoneum, arrangement of peritoneum and greater lesser sac pouches. Not a lot of people know well about them, and it is a difficult subject, so please ask. And what do I need to know? It's in the book. You start with the mind map and then you go to the book. If you have any question, Google it. See what other people say. Bring your question, bring what you have learned, and come and ask me. We will discuss that. Right? Now, the most logical structures to study is anterolateral abdominal wall. Why should we study this? Because the anterolateral abdominal wall is going to protect the abdominal organs, okay? And they help in respiration. Do you know why they help in respiration? Because they either insert or take origin from ribs. Okay? So why am I here and why are you here? Because we have problems to solve. We are problem solvers. Here's a patient with a problem of anterior abdominal wall around the umbilicus. He's not a kid, he is an adult person. And here is a bulging just lateral to the umbilicus. And you can see an old scar here. Again, a kid, a baby, with protruding umbilicus and a swollen right scrotum. This lecture, I'm going to repeat this. This lecture is data management. It is not spoon feeding. What do I need to know? At least to tell parents of this little person. Now look, what do I need to know about the problem of this swelling in the abdominal wall? What is this problem? هسه الحضور غياب أخذ الله معكم ما شاء الله. واو. يلا روحوا وناموا. This is the last time I am going to comment on people who leave the lecture. This is the last time. Okay. What's the problem here? Don't misunderstood the image. This is not the gluteal region. This is anterior abdominal wall, because this is the umbilicus. It is hematoma of anterior abdominal wall. It happens especially in car accident. And what do I need to know? The answer is blood supply of the anterior abdominal wall. Okay? 4 arteries, 2 from below and 2 from above. The from above are, the first word is superior. The one coming up from below is inferior. They go towards the epigastric region. Therefore, the superior ones are called superior epigastric arteries. The lower ones are called inferior epigastric arteries. Right? What is the nearest large artery to the inferior epigastric artery? The external iliac. So the branches of external iliac. What is the nearest big artery to the superior epigastric artery that is going to give these arteries? Subclavian, which is going to give the anterior mammary and then the superior. Okay? You see, in 10 seconds, if I analyze what supplies the anterior abdominal wall, in 10 seconds, the problem is solved by asking the right questions, right? You should not forget this. Here is a problem. Dilated. This is what I need to know. In case of liver cirrhosis, the portal vein gets into the liver and the stream is weak. So there's accumulation of blood backwards. Blood will try to find its way to the systemic veins. And there are 4 areas called portosystemic anastomosis. We've seen the ones in the lower part of the esophagus, and around the umbilicus is another site. So this is a case of severe liver cirrhosis. The anterolateral abdominal wall is very well arranged. It's very well arranged, and it is good enough to have a normal life. But when there is extra stress on it, there are weak areas that small intestine or other organs get out of the anterolateral abdominal wall. These are called hernia. Yeah, there's a special lecture for these hernias. Incision, an operation done on the anterior abdominal wall, and the incision gave way. So there is a way of bulging of small intestine and maybe others. This is called epigastric. This is umbilical. We have seen images of these. And there is what is called indirect inguinal hernia. This is common. I am sure that you are going to see lots of indirect inguinal hernia. The path of descending testis down to the scrotum should be closed and forgotten about by the birth of the boy. Sometimes it is not closed. Or a person has chronic cough, increased intra-abdominal pressure repeatedly, there is going to be a hernia. We're going to have special lecture for that. These are problems. Now, we have problem, we need to think, and we'll find a solution. To understand these problems, Einstein said, I'm not so smart, but I only spend longer time. Don't peek at science. تعرف شنو peeking؟ يعني بقرأ الجملة أنه the blood supply of the abdominal wall, 4 arteries, كذا كذا كذا، خلاص. 3 minutes. You are the first time exposed to these arteries. But this is peaking. But you have to spend some time. Try to calculate what I have just done. Why they are named so and so, and where they are coming from. Spend more time and critical thinking. That's how we learn. Because we are problem solvers. Anyway, what do I need to know about this case? The portal circulation. Problem in the liver. Water blood must come, enters the liver, and goes to the inferior vena cava. But when this pathway is narrowed or blocked, the venous blood will come to the lower end of the esophagus and connects to the systemic circulation and makes these varices. In this case, this patient we have just seen is around the umbilicus, and it is called the caput medusa. Abdominal walls are roof, the diaphragm, anterolateral abdominal wall, posterior abdominal wall, and pelvic wall. These people have left, thanks God. So our story starts here. Why we didn't say anterior abdominal wall and lateral abdominal wall? Why they are combined together? Because it's the same muscles that make the lateral and the anterior. And you can see that the lateral is fleshy and the anterior is aponeurotic. They belong to the same muscle. So that's the fleshy part, and this is the aponeurotic part. These are the layers of the anterior abdominal wall. It is from outside skin, then fat, fatty layer is made of two layers. Superficial one, which is fatty, is called Camper's fascia. The deep part of the superficial fascia is called, and it is membranous, and it's called Scarpa's fascia. The Camper's fascia is continuous with the fat of the thigh. Scarpa's fascia, it doesn't continue. It stops and fuses with fascia lata, 2 inches below the inguinal ligament. So if a person has hematoma on the anterior abdominal wall, and in a few hours or a few days, the hematoma came in and sagged down to the thigh. This means it's in the fatty layer. It is superficial. If the hematoma came down and stopped, then the hematoma is more deep. And this is planned for the treatment. Then 3 muscles. You know these three muscles. Do you know them or you don't? Do you know them? External oblique, internal oblique, transversus abdominis. Let's go through them. Then we have fascia transversalis, and then the extraperitoneal fat, and then the peritoneum. Now, this is a summary of what we have just talked about. In this cadaver, the skin is taken out. This is what you see, the fatty outer layer, Camper's fascia. This fascia is prominent, most prominent below the umbilicus, and it's continuous with that of the thigh. If you try to remove this Camper's fascia, you end up with this site. It is thin, membranous, and glistening. This is Scarpa's fascia. Okay, it's more membranous. The lower aspect of the abdominal wall is most prominent below the umbilicus. Camper's fascia is continuous with the superficial fascia of the thigh, and Scarpa's fascia ends inferior to the inguinal ligament. Now we need this information because of the example I have just given you. This is taking the 2 fascia out, and we start to see the rectus sheath. The first muscle you can see is in this direction, like putting your hand into the bucket, and it ends as fleshy and becomes aponeurotic. The second muscle is the deeper one. The muscle fibers are in this direction, going back. This is the rectus abdominis exposed with its interdigitations. In this cadaver, the fibers are running what? In this direction. Therefore, this is external oblique. The diagram is showing that the external oblique takes origin from ribs. Then from the iliac crest. Okay? And it makes the inguinal ligament and goes to the midline with the rectus sheath. Therefore, it rotates the trunk, and it can be muscle of respiration because it's attached to rib. This is where it becomes aponeurotic. It attaches to the xiphoid process and linea alba. The lower end of the external oblique will turn inward, making the inguinal ligament. It has a hole for the inguinal canal, and there's a ligament here called Lacunae Ligament. We will be talking about this when we talk about hernia. Here is some information. It's the largest, most superficial, flat, and this is the origin and insertion. Okay? Which muscle is this? It's the internal oblique. The direction of muscle fibers are running this way. Ribs 10 to 12. The external oblique was 5 to 12. Lumbosacral fascia. Iliac crest. Inguinal ligament. Okay, pubic symphysis. And it goes to linea alba and xiphoid process. And this is the direction of muscle fibers. Which muscle is this? You can see that fibers are transverse. Okay. Costal cartilages, not from ribs, from costal cartilages. Lumbosacral fascia. Iliac crest. Anterior 3/4 of the iliac crest, because they are not coming from all iliac crest and not from all inguinal ligament, and then inserts the same way. Xiphoid process, linea alba, and lower down is the conjoint tendon and pubic crest. The rectus abdominis. It's the vertical one. It comes from the pubic symphysis and pubic crest and goes up to 5, 6, 7 costal cartilages and xiphoid process. It compresses abdominal contents and flexes the trunk. These are the interdigitations, and this is the rectus abdominis. That's the insertion, costal cartilages and xiphoid process. These are the interdigitations, and this is the pubic symphysis. This is a CT scan of the rectus abdominis. You see the interdigitations. This is a summary. There's a small muscle called pyramidalis. Okay? Between the pubic bone and linea alba. It makes it tense. We will go through this figure when we talk about hernia. Okay. Nerve supply is from the lower 7 intercostal nerves, the anterior and the lateral, and there is a special arrangement anteriorly, it's the rectus sheath. Okay. Now, I will continue formation of the rectus sheath next lecture. Okay.